Good morning, colleagues, and welcome to this webinar on the novel coronavirus COVID-19, where we'll provide you with an update on the response, discuss infection control critical for the prevention of COVID-19, and share on key issues and actions for people living with HIV. This is a PANCAP webinar in collaboration with the Pan American Health Organization. I am your host for today's webinar. I am Dr. Shanti Singh Anthony, Knowledge Management Coordinator at PANCAP. Before we proceed to the presentations, just a few logistic and operational points. Your mics are muted. If you have any questions as the presentation progresses, please type and submit these. We will address them during the question and answer segment after the presentations. We have two presenters today, and we'll take both presentations, and this will be followed by the question and answer segment. We'll share the presentations at the end of the webinar. The webinar is being recorded, and we'll share the recording on PANCAP social media platforms and on PANCAP website. Without further, I'll introduce you to our first presenter, who will then proceed with her presentation. Dr. Eldonna Boisson has worked with PAHO since 1998. She is an advisor for disease surveillance and epidemiology. Prior to her work at PAHO, she served as a research fellow at the London School of Hygiene and Tropical Medicine and clinical scientist at the Public Health Laboratory Services Communicable Disease Surveillance, now Public Health Canada. At this time, she is also one of the 30 PAHO WHO staff on the Regional Incident Management System team for COVID-19, serving as alternate lead in the area of travel and health. I now hand you over to Dr. Boisson.
Good morning, everybody, and thank you very much for tuning in today. I do hope that this session will be useful for you and we'll be able to clear up some of your questions and concerns. Just one little correction. The organization in the UK that I worked with is now called Public Health England. So it was England and not Canada. But let's proceed. So I'm going to speak a little bit about COVID-19. It's what it is and how it's transmitted. Then discuss ways as healthcare providers that you can protect yourselves in terms of the type of PPE you need according to the level of risk that you have. So I'll begin. Let's see. Just 1 second, trying to get the slides to advance. Okay, Shanti, I'm just having a little trouble with getting my slides to advance. They were advancing nicely before. I don't know why they're not advancing now. Okay, there we go. So the first slide, what is COVID-19? Well, it's a coronavirus, which is a large family of viruses that can cause illness more commonly amongst animals, but as we see, it can also cause respiratory illness amongst humans. The range of illnesses are wide. We see some, like the common cold, that very mild illness in the upper respiratory tract. And then we have others like MERS and SARS and now COVID-19 that has the possibility to move into the lower respiratory area and therefore cause problems in the lungs that can be severe. COVID-19, of course, as you know, is the most recently discovered coronavirus just last year, December, in Wuhan, China. The animal source we believe is bats, and we believe there's an intermediary animal that has caused it to be able to move from the bats through this intermediary to humans. It's under investigation and it's not yet confirmed what that animal is. Oh dear. I'm having trouble with advancing the slides. Okay, so moving to the current situation, and as I speak, this would already be old news. This is the situation as of yesterday, 19th of March, and things are changing all the time. But I just wanted to give you a flow where we are now. So globally, you can see we have over 200,000 confirmed cases. And out of that, within the last 24 hours, we actually had over 16,000 of those occurred in the last 24 hours. We have over 8,000 deaths, and about 1/10 of those happened in the last 24 hours. If we break down by region, right now, the European region, which includes Italy as the one with the most cases, is actually the epicenter of the outbreak. The death rate, if you look at the European region, 4,000 deaths, as compared to the Western Pacific region where China is contained, you can see that in fact the European region has a higher death rate at this point in time. So the epicenter has moved, and if you look at the graphic, you can pretty much see that indeed it is a pandemic. The larger red dots represent more cases, and you can see it's very widespread, and right now quite a lot in Europe. And I've just added for our information in the region of the Americas how it compares, and you can see there are much less cases and deaths so far, and that is because we have really just started our outbreak in recent days. If we look here in the Americas, outside of the Caribbean, you can see that the majority of cases are in North America, United States, and Canada. But we see a growing number of countries coming up with cases and some deaths in Central and South America as well. And then getting a little closer to home now, in fact, at home in the Caribbean, we can see that our numbers are starting to move, both in our countries as well as our territories. And we expect as the days go on that we will have increasing numbers and more countries having cases. So we have really just started to have our cases popping up within the last few days in our region. Just want to define a couple of terms that you would have been hearing. One, WHO Grade 3 emergency response. In early January, this was declared. Really, this is something for us in WHO to tell us that this health event requires a substantial response from WHO, both at the country office as well as internationally. So it's a way of telling us how we are supposed to operate in WHO. And at the end of January, the WHO Director General declared COVID-19 a public health emergency of international concern. What does this mean? And I know a lot of times people hear this and think it means that we have an emergency and we have to be concerned. But there's actually a strict definition. In a way, yes, but there's a strict definition. It means it's a health event that is a health risk to other states because it can spread. Normally, there are 4 questions to be answered to determine whether this is a public health emergency of international concern. If 2 of those 4 questions are yes, then it is declared by the WHO Director General as a public health emergency of international concern. The questions are, is it serious? That's 1. Number 2, is the event unusual or unexpected? Number 3, does it carry implications for public health in other states other than where it began or the states that are affected? And 4, does it require an immediate international response or action? So a yes to any 2 of those questions result in the WHO DG declaring a public health emergency of international concern. This is not the first we've had. H1N1, even though it turned out to be a very mild illness, was declared a public health emergency of international concern. So it may be serious, but it doesn't have to be. That's one of the criteria. WHO DG by himself or herself does not determine what is a public health emergency of international concern. We have a roster of experts globally from all countries, or many countries, let me not all countries who have decided to nominate experts are on a global roster of experts. Whenever there's a situation to be considered as to whether it's a public health emergency of international concern, WHO pulls together relevant experts from this roster, and it is these persons from countries around the world who will sit and look at the evidence and so advise the Director General to declare public health emergency of international concern or not. This very same committee will also recommend to the Director General what recommendations need to be made to countries in light of this event. The recommendations are usually temporary because the event is changing, and the recommendations will change as the event proceeds. Pandemic, this is the last term I wish to define. On the 11th of March, so last Wednesday of last week, the WHO Director General declared COVID-19 a pandemic. What is this? Well, first of all, to define an epidemic or an outbreak, they mean exactly the same thing, epidemic and outbreak. They both mean we are seeing something that is above the levels we normally expect to see. So we know, for example, every year we expect to see some dengue. Some years in our region we have that is because we in cases more than we expect to see at that time of the year. Therefore, for COVID-19, because we have never seen it, once we see it somewhere, we declare it an outbreak because we do not expect to normally see it at all. A pandemic means that you are having an epidemic or outbreak throughout the world. This is the first pandemic by coronavirus. As I said, it's the first pandemic we've had. And we've never really been able to control a pandemic the way we are attempting to do right now. The kind of control that we're attempting to do requires a whole of government, as you probably realize, whole of society approach based on a strategy to prevent infections. It cannot be health alone. We need trade, we need education, we need communications, we need finance. So it's a whole of government, whole of society approach aimed at mitigating the impact, saving lives and minimizing the impact. So let's move to COVID-19 symptoms. The most common are fever, tiredness, and dry cough. However, also some people have aches and pains, nasal congestion, runny nose, sore throat, and some even have diarrhea. Now, as I described that should look very familiar to everybody because it is not very different in presentation to flu. The other thing we need to know is that symptoms usually are mild and they begin gradually. There is a lot of fake news of people looking like they get infected and then drop to the ground with dramatic music playing in the background. That is not how it works. Just like flu, it begins mild and begins gradually, and it will progress as the infection moves from the upper respiratory tract to the lower. Infected persons, as with flu, will not develop any symptoms. They won't feel sick. That is not unusual. If you think of the flu, some people will not have symptoms. Some will be down for maybe a few hours or a day. Some will be knocked out for a week. It varies. Symptoms usually develop with COVID-19 on average about 5 days after infection. However, the symptoms can start as early as 1 day after infection and as long as 14 days after. So if you have been infected 1 day and then 14 days after you do not have any symptoms, it means, if you've been exposed 1 day and 14 days later you don't have any symptoms, it means you've not been infected. You've been exposed, but you haven't been infected. Very important to know is that most people, about 80% of people, will recover without needing any special medical attention. And this is what they've seen based on the countries who have been experiencing COVID cases. About 14% will become critically ill with some difficulty breathing. About 6% will require critical care, and about 2% of the persons with disease, at least in China, died. We have seen, however, for example, in Italy, it's been a bit higher, but in South Korea, it's been as low as 0.7%. What makes a difference? Well, several things. The demographics of your population. An older population will probably have a higher death rate. The profile of persons with underlying conditions. Whether or not any mitigation strategies have been taken place. Now, those who are at risk of more severe illness are your older people and those with underlying medical conditions like your high blood pressure, heart problems, diabetes, especially those that are not controlled. Okay, so for most of us, we will get infection. It will stay in the upper respiratory system and you will have your coughing and sneezing, runny nose. But for some persons, more high, it will move down into the lower respiratory system, into the lungs, and that is where it will cause you difficulty breathing, pneumonias, and you will need critical care, oxygen, ventilation, and so forth. So people who find they're having cough, fever, difficulty breathing should seek medical attention. People who know they have underlying conditions, persons with asthma, persons with heart problems, and you are getting fever and cough, and maybe you won't even wait till you have difficulty breathing because you know you are more susceptible. You're having symptoms, they're staying with you and not improving after a couple of days. Go and seek medical attention or call the hotline or call whatever number your relevant country has set to call. Some countries have already put things in place whereby they do not want people to go for healthcare, but they want them to call a particular number or hotline, and so follow the advice of what you have in your own specific countries. Treatments and vaccines. Antibiotics only work on infections caused by bacteria, not those caused by viruses. So as with flu, which is caused by a virus, antibiotics will not work to treat or prevent COVID-19. Now, of course, if hospitalized, as you know, you may have co-infection with a bacteria, and some hospitalized patients may need to be given antibiotics, not for COVID-19, but for the co-infection that they are having. Vaccine, there's currently no vaccine to prevent COVID-19. Flu vaccine, pneumococcal vaccine do not prevent against COVID-19. However, it's still advisable to take your vaccine, particularly your flu vaccine. We're still in the flu season, just come into the still there, so we still have a risk of flu. Remember, you can't have co-infections. So if you can prevent yourself from having both COVID-19 and flu at the same time, that makes sense. It makes your prognosis, should you become infected with COVID-19, better. So it is still good to have your flu vaccine, even though it does not protect against COVID-19. So there's no vaccine and no antiviral medication to prevent COVID-19. However, healthcare providers, you know how to treat the symptoms. You know how to treat difficulty breathing and pneumonias. Therefore, just like with dengue, we have no vaccine, we have no treatment, but we know how to treat the symptoms. So people with serious illness due to COVID-19, or people who know they are prone to serious illness with COVID-19, if they become sick, should be hospitalized and receive the supportive care that healthcare providers know how to deliver for the particular symptoms. Most will recover. Of course, we have vaccines and treatment currently under investigation. However, with respect to vaccines, it's going to be a good 12 to 18 months before we get a vaccine, simply because, as you know, we must have the relevant clinical trials to show, one, that the vaccine is effective, that it actually works, and two, that it is safe. And therefore, we need to allow the time to have the trials so that when the vaccine does come out, it is an effective and safe vaccine. There are many drugs that are being investigated, ones that we already have, to see if they can assist with the treatment. Thus far, they have not found any. There are different papers and things circulating, advocating that some drugs can be used. However, there is no evidence to support that at this point in time. If at any point we do get this evidence, everybody will be updated accordingly. It will be on the WHO website, the PAHO website, and announcements made. Countries will be told directly. At this time, though, there are none. It's supportive treatment. So, how do you protect against COVID-19? Frequently clean your hands with soap and water or alcohol-based sanitizer or rub. Maintaining a distance of at least 1 meter from people who are coughing or sneezing. Why? COVID-19 is spread by droplet infection, not airborne. It is only as far as an infected person can sneeze or cough, and then the droplets are too heavy to carry. They drop at most a meter away. It does not carry in the air. Therefore, if somebody coughs or sneezes in an unhygienic way, not into a tissue or the crook of their elbow, and they do spew droplets with virus, if you are a meter away, they will not carry in the air to you. However, of course, these droplets can drop to the floor, drop to surfaces, doorknobs, handrails. That can happen. However, the virus can only enter on the mucous layers of your respiratory tract. That is through your eyes, nose, or mouth. It cannot enter through the skin, through your blood, if you have a cut or anything. So, if it is that somebody sneezes or coughs in an unhygienic way and spreads some droplets a meter away, and then an uninfected person touches the surface where the virus has fallen, the virus is on their hand. It can remain on surfaces for a difference of a few hours to some days, depending on the surface, the conditions, and so forth. However, should you touch a surface that is contaminated, as long as your hands do not then touch your eyes, nose, or mouth, you cannot be infected. So, avoid touching eyes, nose, and mouth. Soap and water, alcohol-based rub, will kill the virus. It is fairly fragile. The envelope of that virus breaks down with soap and water or alcohol-based rub. So let's say I have gone out, I didn't know there's a surface that's contaminated. I touch it, I need to scratch my eye or my nose or something, or to eat something, put my hands to my mouth. As long as I wash my hands or use the sanitizer before I do that, I am not at risk. So protecting yourself, if you are not infected, maintain a distance from people who are coughing or sneezing of about a meter. Frequently clean your hands with soap and water, alcohol-based rub. Avoid touching nose, eyes, and mouth. It's somewhat akin to if you don't get it in your eye, you cannot get it. If you keep your hands out of your eyes, you cannot get it. Similarly, you keep your hands out of your nose, eyes, mouth, you cannot get it. Of course, if you're infected, you're ill, cover your cough or sneeze either with the bend of your elbow or a tissue. Throw the tissue away. A lot of people like to use a rag if they're sneezing a lot. That's a bad idea because then you end up with a rag full of virus in your hand. So you do not want to use a rag. Tissue, throw it away. If you're unwell, stay at home so that you're not out sneezing, contaminating surfaces. If you have a fever, cough, difficulty breathing, seek medical attention. Don't wait for it to progress, and stay informed on the latest developments about COVID-19. Use of masks. Well people do not need to wear a mask. In fact, well people wearing a mask put themselves more at risk. Why? I see people who are well using masks, and what do? They move it up and down to take something to drink, to speak to somebody, to do something else, and so they're constantly having their hands in their face, moving the mask up and down, thereby putting themselves more at risk. They also wear the mask for a long time. A mask needs to be changed fairly regularly. In our climate where it's warm and it's humid, more than 2 to 4 hours, you probably need to change. Simply by breathing, you're going to be making your mask damp. And once the mask is damp, it's no longer effective as it should be. In fact, it could help to facilitate and be like a wick to bring through the virus. So people wear it for too long, they move it up and down, they put themselves more at risk. Additionally, masks are for people who have symptoms. Why? Because it's spread by droplet infection. If you have a mask and it is covering your nose and your mouth and you sneeze or you cough, you're keeping your droplets in. So it helps to prevent the spread. It's also for persons caring for ill persons like your healthcare workers, yourselves, because it's very hard to care for an ill person if you don't get within 1 meter of them. So if we have this irrational and irresponsible use of masks by well people, it results in wastage and the risk that we don't have masks when we need them, and thereby not only directly by moving the mask, touching your face, using a damp mask, that's directly putting yourselves at risk if you're well, but also indirectly by contributing to having this shortage. And people who really need them to reduce spread don't get them. So if you as healthcare workers can spread this message to people, that would be a really good thing. Some mythbusters, please, again, spread the message. Some of these things here are things that people are saying and that you're seeing spreading like wildfire on social media that will prevent or cure COVID-19. None of these things do. Bush bath, bush tea, vitamin C, zinc, your vitamins and minerals, you absorb the dosage that your body needs, the rest is excreted. Large amounts, more than the recommended dose, is literally flushing your money down the toilet. Hot toddies might help your throat to feel a little soothed, but it doesn't prevent or cure. Garlic and other spices, I don't know, maybe garlic helps with social distancing, but COVID is not afraid of garlic and spices. And these other things, oils and gels, disinfectants or bleach on the body, please, that's for surfaces, not for the body. So when you have people asking you as healthcare providers about these things, please dissuade them. Let them know that these things will not protect the things we spoke about, the good hygiene, hand hygiene, cough etiquette, those are the things, social distancing. So we've been through this before. Wash your hands after you cough or sneeze, when you care for sick, before, during, and after preparing food, before eating, after toilet use, if your hands are visibly dirty, after handling animals or animal waste. These are things we should be doing anyway, and these are things that are effective to protect us against COVID-19. Also, if you are sick, avoid close contact, no spitting in public, no kissing. If you're doing open mouth kissing, obviously you can spread the respiratory secretion. Seek healthcare. Cough or sneeze into a tissue or elbow, throw it away, clean your hands. I want to move to infection prevention, control, and the use of personal protective equipment at this point in time. Infection prevention control is used to limit human-to-human transmission, reduce secondary infection, and prevent transmission through super spreading and amplification. Now, standard precautions started in '85 with HIV and the discussion of universal precautions. Then in 1987, we moved to body substance isolation. And then later in the 1990s, we moved to standard precaution and transmission-based precautions. Your standard precautions are those sets of practices that you should apply whenever caring for patients, regardless of the state of infection, whether they're suspected or confirmed, wherever you're providing healthcare services, you should practice standard precautions. What are these? Hand hygiene, soap and water or alcohol-based solutions, use of protective equipment according to risk, and I'm going to speak about risk in a minute. I'm running over a little bit on time, but if you can bear with me just for a few more minutes. Respiratory hygiene or cough etiquette, safe injection practices, you know what those are, not reusing needles, so forth. Sterilization, disinfection of medical devices, and cleaning the environment. All of these are things you should be doing in your healthcare facility routinely, whether you have confirmed cases of COVID-19 or anything else, or suspected cases. These are standard precautions that should be taken at all times. Now, depending on the way the organism is transmitted, there are additional transmission-based precautions that should be taken for specific types of viruses, bacteria, parasites, and so forth. You have contact precautions, droplets, and airborne. For any suspected or confirmed case of COVID, you should have your standard that we spoke about, as well as contact and droplet, because that's how it's spread, by droplets. Now, if you're doing aerosol-generating procedures on a confirmed or suspected case, standard and contact as well, but you up it from droplet precautions to airborne precautions, because when you do aerosol-generating procedures, you are actually now forcing the virus out and it can spread further. You have to evaluate your risk to determine your PPE. How do you do that? You think about, what is my interaction with the patient? How is the disease transmitted? It's different if it's droplet as compared to airborne. How much body fluid will be generated? Some other questions to think about. Does this patient fulfill the case definition criteria for the disease? That will help you determine risk. What is the infectious agent? How is it spread? What kind of procedure is the patient undergoing? The risk of contamination. Where should I have the patient? With other patients, isolated, and therefore what kind of PPE should I use? Again, despite whatever PPE you use, hand hygiene is a must. You should also replace any of your PPE once you see it's damaged or broken. So even if you're seeing a patient and using gloves as PPE and you see that it's torn, stop, throw it away, wash hands, new ones. Remove all your PPE as soon as possible after you complete your care. Dispose of it appropriately. So let's look at the individual pieces of PPE. Gloves. Gloves are used to prevent you from being exposed to direct contact with blood or any other body fluid of an infected patient. So in this instance, we're talking about respiratory secretions. As a healthcare worker, you may have to put your hands by the nose, eyes, mouth of the person that you're dealing with, or further in if you're trying to take samples. So gloves. Gloves do not replace hand hygiene. You must wash your hands after you take them off. Gowns and aprons. This is used in addition to gloves if there's a risk of fluids or blood from the patient splashing onto your body. Now, you could use the same gown for more than one patient if you have them in one cohort area. So let's say you have a ward with suspected cases of COVID. They're a meter apart, of course, and you are caring from one patient to the next in that ward. Once your gown does not have direct contact with a patient, you can use it with the next one. Even if it's confirmed cases a meter apart, once the gown has not contacted the patient. Now, once you've finished with that cohort, obviously you must not use the same gown to go out and deal with others. If the gown is not waterproof, fluid repellent, then a plastic apron on top, because remember, the whole point of this is to prevent liquids. Your facial mucosa protection, like your goggles or your eye shields, to protect the eyes or nose or mouth of the healthcare worker from risk of contact with the patient's respiratory secretions or splashes. So this protects if you're going to be within that meter and you need to protect those mucosal layers. Medical mask. You wear medical mask if you're treating within a meter range of a patient. You have the patient in a single room or only with other patients with the same diagnosis. So maybe all suspected together or all confirmed together, 1 meter apart. You also want to try to make sure the transport of the patient to areas outside the room is at a minimum. So let's say, I don't know, you have to do a procedure. If you can bring the equipment in and do it in the room, that is better than taking the patient to the equipment. Of course, that is not always possible. So if you must move a patient, suspected or confirmed, out of the room where they're being treated and isolated, you need to put a medical mask, not your N95, medical mask on your patient as well as the person taking them. Try and take them through a passageway that has little or no traffic. You can possibly even attempt to have the passage clear as you pass and then bring them back. Again, perform hand hygiene immediately after you remove your medical mask. Your respirators, your N95s, this is when you are providing care to patients when doing aerosol-generating procedures. If you're just providing routine care and it's not aerosol-generating, it's not your intubations and so forth, you only need a surgical mask because, remember the questions in terms of how it's transmitted, it's droplets. It is only when aerosol-generating do you need your N95 mask, making sure that the seal is good so that when the aerosol spray comes, you are protected. Again, hand hygiene when you remove. I know you know aerosol generating procedures. These are some of them here, and we will share the presentation. So if you are not performing these, a medical mask is sufficient. So PPE according to level of care. Triage. If we are looking at across the top, the different kinds of PPE, we have hand hygiene, gown, medical masks, your respirators, goggles, and gloves. If you are only triaging, so let's say you are a healthcare worker who is seeing a patient or seeing potential patients coming into a healthcare facility, and you are more than a meter away, you do not need to have PPE other than hand hygiene. Hand hygiene is across the board, regardless of whatever else you use. Why do you not need? What is your risk? There is no aerosol generating procedure, so it's not airborne. It is droplet, which means it can only reach a meter away. So that even if the person you are triaging were to cough or sneeze, the droplets will fall a maximum of a meter away. So that if you're triaging a meter away, you do not need anything more than hand hygiene. You also want to consider things like if you have a barrier, like a glass window, say, with no holes, glass window, again, you already have a barrier. If you are within a meter, you need to then have your medical mask because droplets can reach to you. If you are collecting specimens for lab diagnoses, you need your hand hygiene, you need your gown because you can have, if you're collecting, you can have spillage of the secretion, N95 or respirator, that would be also depending on what you're doing, goggles, gloves. If you have a suspected or confirmed case of COVID with no aerosol generating, you're treating, but it's not aerosol generating, hand hygiene, your gown, medical masks, goggles or your face shield, and gloves. If you are treating and doing an aerosol generating procedure, same as above, but instead of a medical mask, you need to up to a respirator, N95 or your FFPs too. Seems to be stuck. Just give me a minute. Okay. Cleaners. If you have your goggles, hello, Shanti, do you hear me now?
Yes, Eldonna, I can hear you now. Please proceed.
Okay. So the cleaners, gloves, of course, they're going to be heavy duty gloves because they're doing cleaning. So what they would use for cleaning. It's not on this slide, but definitely you need to have closed up shoes, not the booties or anything, but just closed up shoes that you normally have when you're cleaning. Visitors entering the room of COVID patients, you want to limit that as much as possible. But of course, some patients will need to have visitors, children, maybe older people. If somebody must go in, again, hand hygiene, they should have a medical mask to prevent droplet spread and a gown. Other areas of the hospital, administrative areas, do not need any additional PPE, just hand hygiene. Okay. Okay. And my very last slide, in terms of hospital readiness overall, and I won't stay too long on this, there is a checklist that all countries have for hospital readiness, where they will look at things in the hospital like leadership. Do they have the management team, the coordination, information, logistics, operations, isolation, infection prevention, control, case management, diagnosis, and so forth. And there's a checklist in terms of those things that you want to make sure that you are considering to make sure that your hospital is ready. So in summary, the use of personal protection really requires an evaluation of risk. What is my risk? And therefore I match my PPE to risk, knowing how it's spread, knowing what procedure I am doing, I then use the appropriate PPE. As we said, any suspected or confirmed case of COVID that is not aerosol generating procedure you're doing, standard plus contact plus droplet procedures, precautions, sorry. If you're treating suspected or confirmed and you have aerosol generating procedures, then standard, contact, and airborne precautions. Finally, stay informed, use reliable websites like WHO, PAHO. Sorry, I have this from an old slide, the Trinidad and Tobago Ministry of Health, but you all have your own ministries of health. Check those as well. So I thank you for attention. I'm sorry being a little bit over the time, but I hope that was over.
Thank you very much. Thank you very much, Dr. Boisson. I encourage participants to please submit your questions. At this point, I introduce you to Dr. Giovanni Ravasi, who is a medical doctor specialized in infectious diseases and public health, with experience in HIV and STI clinical management training and mentoring, surveillance and research, and technical cooperation on HIV prevention, care, and treatment policy development. Since 2008, Dr. Ravasi has worked for PAHO as the regional advisor for HIV drug resistance, prevention, and surveillance. And from 2014, for HIV and sexually transmitted infections, care, and treatment based at PAHO Headquarters in DC. Dr. Ravasi will present to us on COVID-19 and HIV. Over to you, Dr. Ravasi.
Thank you so much, Shanti, and I hope you can all hear me. Good morning to all the people that are participating in this webinar, and thanks to PANCAP for the opportunity to share some specific information and key issues and actions related to COVID-19 and HIV. And coming after Eldonna's very comprehensive presentation, I will really focus on some of the key issues related to COVID-19 and HIV, and hopefully we'll have some time for question and answers. The content of this presentation brings together an update about COVID-19 and HIV, and some actions that are also included in a brief that is being prepared by the UNAIDS co-sponsors regional group for Latin America and the Caribbean, and that will soon be available. This issue is, as you might understand, a living document, because really on a daily basis, there's new evidence, new information, new guidance. So it's really important to keep yourself up to date about the most recent information. So this document and my presentation will include some general information about HIV and COVID-19, prevention for people living with HIV, preparedness for continuity of HIV services, some human rights considerations, the role of civil society, which is extremely important in the context of the HIV response, and nonetheless in the context of COVID-19, some information about emergency funds and COVID-19 resources that are available. So in general, patients with severe immunodeficiency are at high risk of complications with any infectious diseases, but there is very limited evidence about coronavirus and HIV. There are 3 cases, case reports of HIV and coronavirus infections related to SARS, MERS, and the new COVID-19 virus. All these cases mild to moderate, and all recover despite of severe immunodeficiency. So there are a number of hypotheses that are being investigated to understand whether there are protective factors related to vital interference or the protection of use of antiretrovirals. And also in cases of patients with AIDS symptoms hospitalized together with SARS patients, there was no observed transmission, inter-hospital transmission of SARS virus to patients with AIDS. So in general, there's currently no evidence to suggest that people living with HIV are at a higher risk of acquiring the SARS coronavirus to infection, but also to develop more severe COVID-19 illness compared to HIV negative people. Of course, as Eldonna mentioned, people living with HIV who are older or have underlying conditions may be at risk of developing more serious COVID-19 related illness as anyone in the general population, and possibly also people living with HIV with a lower CD4 count. So it's extremely important that countries and services implement WHO recommendations of treat all, regardless of CD4 count in case of HIV confirmed diagnosis, as well as rapid initiation within 7 days from diagnosis, really to obtain in the shortest possible time vital suppression and immune recovery. In this context, it's also extremely important to highlight the importance of keeping optimal adherence, again, to achieve viral suppression and immunological recovery. For people living with HIV, the general preventive measures that Eldonna presented apply as for the general populations, and vaccinations, especially influenza and pneumococcal vaccine, should be offered to all people living with HIV and be kept up to date. Again, as Eldonna mentioned, there is no anti-COVID-19 treatment at the moment, and the treatment is symptomatic. For your information, there's also a frequently asked question page on COVID-19, HIV, and antiretrovirals on the WHO website that can be consulted, and it's going to be maintained up to date with new information. So there's a guidance available from WHO about the treatment of COVID-19, and there's no current evidence to recommend any specific COVID-19 treatment. There are some antivirals agents that are currently under investigation. Especially regarding antiretrovirals that are used for the treatment of HIV, there are some studies that have been implemented in the context of SARS and MERS, and now with COVID-19, especially looking at the potential effect of lopinavir, ritonavir, and darunavir cobicistat. But at the moment, there is no evidence that the use of antiretrovirals is effective for the treatment of COVID-19. And actually, very recently, a study on the use of lopinavir, ritonavir in cases with severe COVID-19 was published in the New England Journal of Medicine. And again, confirming that there is no significant difference between the use of lopinavir, ritonavir, and standard of care with symptomatic interventions. So in the context of the COVID-19 pandemic, it's really important that HIV program make sure that antiretrovirals are available for people living with HIV, and not diverted to COVID-19 treatment because at the moment there is no evidence of their efficacy. So as Eldonna mentioned, the situation is really changing, and there are many trials being conducted at the moment in different parts of the world, and stringent regulatory authorities such as FDA and public health agencies like PAHO and WHO will share all the most recent information about the use of possible effective COVID-19 treatment. So you might have heard about chloroquine, and you can access the website of the Federal Drug Administration of the United States, and it's confirmed that right now is at the level of a study to determine the efficacy in using chloroquine to treat COVID-19. So for people living with HIV, as I mentioned, all the general precaution apply, and I'm including here some of the links to PAHO and WHO website with all available information. And also UNAIDS has developed a specific orientation and information sheet for people living with HIV that is available on the UNAIDS website. And including the pillars of stay safe, stay informed, be prepared, support yourself and people around you, stop stigma, and know your rights, and information about the treatment of COVID-19. So there are important preparedness actions that HIV program can adopt to ensure continuity of HIV services. And we already have a couple of examples of countries in the region, such as Brazil and El Salvador, that have very timely put in place specific strategies to ensure the continuity of HIV services while reducing the burden of health services in preparation for COVID-19 epidemic. It's important that ministries of health and HIV programs develop contingency plans for the continuity of HIV services at all levels. And there are some differentiated service delivery strategies that have been recommended by WHO since 2016 and that are extremely useful in the context of COVID-19 preparedness, because they have the potential to reduce the burden of services, such as less frequent routine clinical consultations, especially for persons that are stable on treatment, less frequent ARV drug pickup with multi-month prescriptions and multi-month dispensing for 3 or 6 months, and in countries that are implementing PrEP, also a minimum supply of 3 months for PrEP users. There are ways of facilitating access to ARVs at the community level through community pharmacies or home delivery that could be explored, and also remote adherence support and remote clinical appointments and follow-ups, especially also in case of people living with HIV that are isolated or quarantined, using telemedicine, online portals, virtual telephone and messaging, and WhatsApp. So really the idea is to minimize the burden of HIV services, because even in the context of COVID-19 epidemic, it will be important to prioritize HIV services for those persons that have a low CD4 count, that have underlying chronic conditions, co-infections such as HIV, TB patients. And in these cases, of course, all the infection prevention and control measures that Eldonna presented apply to HIV services and community-based services to ensure the safety for personal and clinical personnel and patients and clients. In the context of COVID-19 preparedness, HIV testing services should be maintained, because people living with HIV who do not know their status still need to be to have access to HIV testing to be linked and put on treatment as soon as possible. So health facility-based HIV testing, provider-initiated or voluntary, could be prioritized in the context of COVID-19 preparedness. There may be some concern about community-based HIV testing. In some cases, these may be temporarily put on hold based on recommendation of social distancing. But even in community-based services, it is important to ensure that all infection prevention and control interventions are adopted, and again, to ensure the safety of providers and clients. And we also consider that HIV self-testing in the context of COVID-19 preparedness really could be an opportunity to still provide access to HIV testing while avoiding accessing services and overburdening health services. So I think the idea of the preparedness for continuity of HIV services is also taking this as an opportunity to improve the way HIV services are provided in terms of differentiated service delivery approaches, as well as some introduction of some technologies. It's extremely important also to make sure that all the interventions respect human rights, and the engagement and participation of community leaders is something that is fundamental in the HIV response, and it's as well critical in the response to COVID-19. So community leaders and representatives of people living with HIV and networks should be included in preparedness and planning tables to ensure transparency, trust, and improve the effectiveness of the interventions. The restriction of movements should be of limited duration and based on scientific evidence. And there's also an extremely important need to fight xenophobia, racism, stigma, and discrimination against groups that are considered to be affected by COVID-19. And there are some guidance that have been developed by the Red Cross, UNICEF, and the World Health Organization that are available. But again, of utmost importance is that people be kept up to date with reliable information, fighting fake news, and this includes information on social media that are now a very important way of delivering communication to the general population. So there has been work from the World Health Organization to work with Facebook and Twitter and Google, and so that official information from the World Health Organization is given priority in these platforms when people are looking for information about COVID-19. So finally, a few considerations about the role of civil society organization and people living with HIV and their networks. Again, fundamental to engage civil society and ensure participation in the COVID-19 preparedness and response. Monitoring the needs of people living with HIV, their needs for information, for preventive support, care, and treatment gaps that might appear in the context of COVID-19 epidemic, as well as advocating for differentiated service delivery that we just mentioned. Community-based services are fundamental in the HIV response, especially for most vulnerable people living with HIV. So these should be guaranteed as much as possible, but of course, making sure that standard operating procedures for infection prevention and control are adopted as recommended by local health authorities, again, for the safety of providers and clients. There are some emergency funds for COVID-19 that are available. Countries that are receiving Global Fund grants should find out about the emergency use of these fundings for the COVID-19 response. The World Bank is also mobilizing emergency funds, and WHO also has opened a Solidarity Response Fund to receive donations in support of the global response to COVID-19. So the situation, as you can imagine, is highly dynamic and experiences, evidence, and guidance is really being updated regularly and frequently. So it's important that everyone stays informed and consulting official and reliable sources of information. There's a great deal of experience that has been learned from previous outbreaks, and we know that the community engagement and ensuring human rights in the COVID-19 response is fundamental. Another important resource that is available for the region is the PAHO Virtual Campus on Public Health, and a couple of courses that are available for healthcare workers. And again, stay informed. These are some of the most important links and a question and answer page on the WHO website, specifically on COVID-19, HIV, and antiretrovirals. So thank you so much again, and available for questions and answers.
Thank you very much, Dr. Ravasi. I think we've had two excellent comprehensive presentations. So thanks again to Dr. Boisson and Dr. Ravasi. We have a few questions and I'll get right into them. The first question that I have, there are several questions in one, so if I can ask the presenter to take note. The advice with respect to testing of only persons with symptoms seems at odds with the data that shows that asymptomatic persons may be infected and be able to spread the infection. How should countries deal with this? Shouldn't persons who are contacts of cases be tested based on time frame when exposure took place regardless of the symptoms? Anyone?
Yeah, I can take, this is Eldonna Boisson speaking. I could take a first stab at that. So testing strategies should really vary depending on where you are in your outbreak. If you are at the start of your outbreak, where you would start obviously with imported cases because you didn't have this before, so your first cases would obviously be imported. At some point, you'd possibly move to having community spread. At the start of an outbreak, yes, it is recommended to test symptomatic persons who you think are suspected case of COVID. Some countries have widened the testing to test all persons who meet the clinical case definition in terms of like the fever, cough, and so forth. Some countries have gone a step further and are also testing contacts of cases, persons who have been exposed, even if they are asymptomatic, because we do know, as I said, the symptoms show a range from asymptomatic to very severe. I believe in the Caribbean, most of the countries are using the protocol of only testing symptomatic persons. But at the start of an outbreak, if you would like to find out as quickly as possible if you have moved to community spread, then yes, it makes sense to the testing that you're doing. Of course, you have to take into account capacity, the capacity of the lab that you have. Does it have the capacity to do testing of all contacts? So certainly if you have a capacity limitation, you would limit to symptomatic suspected cases. If you can expand, then it would be wise to expand to cases who fit a clinical definition to see if you have community spread. And if you have more capacity, even asymptomatic who have been exposed, who you know have been exposed. So not just random testing of the population, of course, but those who you suspect may have been exposed or actually are suspected cases. As the epidemic progresses and you know you have local spread, then it makes sense to pull back with the testing because you already know you have local spread. And then you would be testing cases that have been, for example, hospitalized because you want to see if there has been any change in the more severe persons. So that would be my response. Over.
Thank you. Thank you very much, Eldonna. Giovanni, would you like to add anything, or can I move on to the next questions?
I think you can move on to the next question.
Okay, so here's a comment and question. Thanks, Eldonna and Giovanni, for this informative session. I note and appreciate that emergency funds are being made available by many agencies and multilaterals. However, the Caribbean depends very heavily on the US and Europe for supplies and reagents. I fear that we will be faced with shortages. Do you have any suggestions on how or if we can mitigate this problem? Anyone?
Can I just clarify, these are shortages of medical supplies?
Supplies and reagents.
Shortages of medical supplies that you're speaking of?
This is the question that came in. It says specifically supplies and reagents. I suspect yes.
I can take a first stab. We have been getting, when I say we, WHO and PAHO, we have been getting donations from different places, different governments, Some are money donations, some are donations of supplies. And what has been happening, I sit in the Trinidad and Tobago PAHO office, and I know the funds are going directly to the PAHO country offices who are in contact with the relevant national authorities and are working with them to be able to use the funds to procure whatever they need. And if it is that the supplies or reagents are not available for procurement, the headquarters incident management system team is moving towards acquiring what is needed. So far, providing the funds, and for example, lab testing, PAHO has been providing the reagents, for example. So at this point in time, I think the Caribbean is still okay in that regard, and the pledges and the donations, the actual donations, the funds, the materials are actually coming in. The International Atomic Energy, of which almost all the Caribbean are members, they've not limited only members. They have already reached out to several countries bilaterally, asking if there's anything that they need in terms of testing. They're willing to supply those as well. So far, we're not, fortunately, in this instance, relying predominantly on the US. There's a lot of donations coming in from various sources, and they're being sent to the countries. I don't know if you have more to add on that.
Thank you. Maybe just a consideration regarding antiretrovirals. And it would be important for all programs to assess current stocks. We are experiencing an long lead time to delivery of antiretrovirals. And so it would be important for programs to assess current stocks, make sure that they have enough emergency buffer stock in their ARV procurement plans. And considering the importance of implementing multi-month dispensing, countries could review their procurement plans and maybe anticipate or accelerate the processes of antiretroviral procurement compared to the usual procedures.
Thank you. Thank you very much, Giovanni and Eldonna. A few questions and comments specific to people living with HIV. First question, we have a monthly support group for people living with HIV. What are some of the things we should be telling them about the coronavirus? I'll go through some of the more HIV related comments and questions. So that's the first. The second comment and question is, just bear with me 1 second. Social distancing is being promoted. How do treatment teams manage the volume of people living with HIV at their clinics? Thank you both for your presentation. What is the recommended approach for mental health needs of people living with HIV, given the fact that personal interaction is being discouraged? And then we have a comment from UNAIDS Latin America team to say, make sure that people living with HIV networks are included in your HIV COVID-19 response. They can support ARV treatment and IC on COVID-19 and HIV. Is there an intention to have any session for people living with HIV to get some appreciation of their fears and concerns? So those are some of the comments and questions on HIV. Giovanni?
Okay, so I will try to answer some. So regarding what to advise, I think we're not going through the advices right now, but I presented in my slides all the sources of information and about the general precautions, which of course apply for people living with HIV, and extensive and detailed content about what people living with HIV should know about COVID-19 is included in the UNAIDS brief. This I specifically included all the links in my slides so that when Shanti distributes the presentation, you will all have the possibility to access all the sources of information. And of course, mental health is a fundamental aspect in the context of social distancing, and that's I think one element where social media and remote communication with the different platforms that are available, both with the health team, but also with civil society organizations and peers, becomes extremely important to still provide support and mental support to people that are isolated or quarantined. I think for HIV multidisciplinary teams, how to handle the service, I think there are some suggestions in the slide that I presented about the continuity of HIV services, and countries like Brazil and El Salvador have started developing some specific guidance for HIV services on how to reduce the burden, prioritize persons with HIV with low CD4 count, unstable conditions, co-infections that might require specific care, while minimizing the need for stable patients to go to services. To reduce the burden of the health of the multidisciplinary teams, but also to reduce the risk of stable persons on ART to expose themselves to the virus. So spacing, consultations, multi-month dispensing of treatment, when possible, doing remote adherence support, in some cases even remote clinical consultation and follow-ups if no major clinical issue is presenting. So these are all things that can be put in place. And if we consider that in most cases up to 70 or 80% of people living with HIV are on treatment and with vital suppression among those on treatment in programs, then this might really reduce the burden a great deal.
Thank you very much. A few more questions. First, is there a timeline for WHO re the role and evaluation of simpler testing strategies beyond PCR? For example, antibody and antigen antibody ELISAs and rapid tests, key for expanding testing. Second comment, procedures regarding disposal of contaminated biomedical waste should also be addressed to prevent waste disposal personnel from being subjected to the risk of exposure to COVID-19. Those two.
In terms of the lab testing, yes, there's lots of research going on right now to try and identify tests for testing antibodies, for doing rapid testing. There are none as yet. In terms of the antibodies, it's a little bit more difficult right now because all we have is doing 2 tests, to have an acute sample and then a convalescent sample, and to look at the change in titers. As you know, it's very difficult to get a second sample unless you actually have somebody hospitalized. to get that convalescent sample. So that is not ideal. But until such time that a new test has been developed for the testing of the antibodies that you can package into a rapid test, that's the best that can be done. So right now the tests are really the tests looking for virus. But, you know, watch this space, it's going to come. It's just taking a while to develop. Remember that the disease only arrived in December, which we're talking just a few months, just like 3 months away. So there's a lot of investigation worldwide and will come. In terms of waste disposal, there are guidelines on the WHO website, so I can have a look at that and try and find the exact one and send it to Shanti for her to share. I do encourage you to go to the WHO website. It is and the PAHO website, which links to WHO. It's very user-friendly. Everything's broken down in terms of, you know, what the public needs to know, technical documents, situation reports. Is pretty user-friendly. So I'll look and see if I can find the exact one and send that to Shanti to share. But essentially, again, just like considering your personal protective equipment or how to protect yourself in a healthcare facility, in terms of waste disposal, it's the same thing. You need the same approach, I should say. You need to consider, what is my risk? And then based on my risk, what personal protective equipment should I use? Okay, but I will try and find that and send it so that it can be shared along with the presentations. Over.
Thank you very much. Thank you, Eldonna. Comment on a question. Comment saying we have received, I think this is from UNAIDS, we have received support from PAHO for reagents and have made our own procurement process. We now have capacity for more than 3,000 tests for COVID-19. We'll duplicate it by next week and 10,000 in 2 to 3 weeks. This probably is from Trinidad. Question, excellent presentations. Many reproductive and health commodities, including condoms, are manufactured in China and factories were closed during the outbreak. There is therefore likely to be condom stock out. Any suggestions?
Well, you know, right now I think everything is very uncertain, not just condom stockouts. We hope that it doesn't get to that. In fact, first of all, in terms of China, China has come to the end of their outbreak. Again, we don't know, will they see another outbreak amongst persons who are susceptible and were not infected the first time? We don't know. There are many, many unknowns. But right now, their percent is Europe, China has already passed the peak and their outbreak is pretty much over. In terms of production from China this time, that is able to pick up. I mean, I think generally we have to just be sensible in what we're doing and how we're using the commodities we have, including condoms. I wish I could say I knew when this would all be over, but I don't think anybody has that answer, unfortunately. I don't know, Giovanni, if you had anything to add, but it's just many, many unknowns now.
Yeah, we might actually take this to UNFPA colleagues. I'm not sure if anyone is on the line, but we'll look into it.
Okay, thank you. Thank you both. Comment, we have quite a few HIV rapid testers who are within the high-risk groups for COVID-19, over the age of 70 or have been compromised or have immune-compromised systems. They would like guidance on HIV rapid testing, although it is not a procedure that directly exposes them to droplets. They're concerned due to the fact that they test in small rooms with AC. They were directed to continue testing once PPE, gloves, gowns, and masks were used. Any comment?
So yes, and I think this is something that needs to be addressed very, very quickly and timely. because community-based services are fundamental for the HIV response. And there are different levels of risk involved in counseling or condom distribution or sample collection in case of application of rapid testing. So I think it will be important to really quickly develop some evidence-based infection prevention and control guidance for community-based work to make sure that these services are performed in the safest possible way for users and providers. And Eldonna, I'm not sure if you have any comment on that.
Yeah, I agree. Obviously, those services must continue. One of the things would be to try and ensure the social distancing where people have to go for these services. You're 1 meter apart. It might mean a different type of scheduling. It might mean a different kind of flow in the facility. In terms of doing your rapid testing, again, with the right personal protective equipment, your gloves, gowns, mask, yes, it makes it safe. So facility, I think, needs to think about that. How are you scheduling? How are you having the flow of persons moving through the facility, and to try as much as possible to maintain that social distancing and to provide the relevant personal protective equipment for the persons who have to be doing the tests.
Yeah, okay. Thank you. We have just a few more questions. Any comments on asymptomatic transmission? I think if there's anything to add to what was already said. And there is one question, I think we've addressed this, but I would still share. Do you have any guidance on how to use chloroquine for treatment?
Okay, so I can start with asymptomatic transmission. Again, think back to what I said in terms of how is it transmitted, by droplet infections, which are heavy. So if somebody is not symptomatic, those droplets do not come out and it's from the respiratory tract. The way it most easily comes out is by coughing and sneezing. If somebody is not symptomatic, they're not coughing and sneezing, and so they are not producing droplets. So they cannot spread in that way. How can an asymptomatic person spread infection? Again, remember, it's passing the respiratory secretion from an infected to an uninfected person. So things like open mouth kissing, because the respiratory secretion from the infected is directly reaching the uninfected. Things like sharing utensils, eating utensils, again, passing respiratory secretions directly from infected to uninfected. Also, if an infected person, if they are asymptomatic, but for some reason they have put their hands in their eyes or their mouth or their nose and they have secretion on their hands and they touch a surface, yes, that surface can be infected and it can linger there for a while. So routine cleaning helps to remove that. But let us say the surface has not been cleaned and an uninfected person touches it, and then they touch their nose, eyes, or mouth, then yes, the virus can get into the uninfected persons. So asymptomatic persons can only transmit if it is directly having contact of their respiratory secretions with the respiratory secretions of somebody else, or they transfer it to a surface and some uninfected person transfers it from that surface to their respiratory secretion. So proper hand hygiene by both the infected and uninfected, and cough etiquette, well, won't be cough if they're not asymptomatic, but proper hygiene and hand hygiene in particular and sanitation will help prevent. But this asymptomatic cannot spread by droplet infection because they are not having symptoms to produce droplets. They cannot spread by airborne because it does not carry in the air. In terms of chloroquine, there's no evidence to suggest that it is effective in treatment. There's been no drugs so far. They are investigating many, and that investigation will continue. But at this point in time, there's absolutely no evidence to suggest that chloroquine or any other drugs are effective in prevention, cure, or treatment of COVID-19. Over.
Okay, thank you very much. Thank you very much, Eldonna. I think this brings us to the end of the webinar. But before I close, I'll hand you over to Sandra, who I think would like to make a few comments. Sandra?
Yes, good morning, everyone. I just want to take this opportunity to thank my two colleagues, Eldonna and Giovanni, for this very informative and concise presentation. Eldonna walk us through by providing a very detailed information as it relates to how to protect ourselves, what are the signs and symptoms, and also to try and demystify some of the myths that have been surrounding the whole issue of the COVID-19. She emphasized and placed focus on the infection prevention and control, focus on limit human-to-human transmission, reduce the secondary infection, prevent transmission through amplification and super spreading events, and of course reminded us all of the standard precaution which needs to be applied in health settings. When I know there have been lots of concerns in the region about persons living with HIV and actually getting COVID-19. Giovanni clearly has in his presentation noted that there's no evidence to suggest that people living with HIV are at higher risk of acquiring COVID-19 as opposed to versus those who are HIV negative, and that people living with HIV should take the general precaution measures for COVID-19 that is recommended for the general population, which is recommended for all of us. And of course, the engagement of civil society in the national planning and preparation for the COVID-19, but for all other health concerns that we have. And of course, both presenters emphasize the need to get information from reliable sources as much as possible, and to avoid all the fake news. I know we have gone way over the time allotted. I want to, on behalf of PAHO and the Pan-Caribbean Partnership, I want to thank all of our Ministry of Health colleagues, our key partners for and civil society organization for joining this webinar, and for your active participation, for your questions, your comments, which were very useful. I also want to use this opportunity to thank PANCAP Secretariat for the ongoing support, their collaboration and their partnership, especially Shanti and Timothy, for the utilization of this platform to reach the community, the Caribbean community, on sharing specific information such as what we did here today. So I am sure you have found the information very useful. You can share with others. It will be available. And as you all know, we all have a role to play as we strive to reduce this community transmission in our countries. Thank you very much. Just before I also hand back over to Shanti, I want to actually mention that, and I think Giovanni spoke to it in his presentation, that we have online courses on COVID-19 for healthcare providers, and we will also be sharing those links so that you will have those. And it's very short courses. You could take them in your own at your own timing. So thank you very much, and we look forward to your active participation in other series to follow. Thank you. Shanti, over to you.
Thank you. Thank you very much, Sandra. Once again, thanks to PAHO and our presenters for this really important collaboration. As a gentle reminder, we'll share the presentations, both presentations, with you via email. The webinar will also be posted on PANCAP social media platforms and on the website. As both presenters noted, this situation is very dynamic, and so I encourage you to stay tuned. We will continue to share updates and information with you as new knowledge becomes available. Thank you very much, colleagues. Stay safe, stay informed, and be prepared. Have a good day, everyone.
Thank you. Bye.
Bye. Thank